It's a great pleasure and privilege to be here today in this warm city for sharing with all of you my experience on the topic of PPI-SIBO relationship. As you know, PPI are potent inhibitor of gastric acid secretion while prescribed by both primary care physicians and gastroenterologists, with increasing use in over-the-counter selling. They are considered to be and to have a high safety profile, although they can cause diarrhea, enteric infections, and alteration of gut microbiota. The gold standard for SIBO is considered to be duodenal jejunal aspirate culture, that is, however, an invasive and cumbersome procedure with limited sensitivity because of limited accessibility to the proximal tract of the gut. Hydrogen breath tests are ingress surrogate tests for SIBO, yet they present several advantages. They are non-invasive, easily repeatable, sensitive enough, and specific for SIBO diagnosis. Although they can be criticized, they are the only recognized non-invasive clinical tools for SIBO diagnosis largely used worldwide. So, the aim of my talk are verify PPI-SIBO relationship and assess eradication rate of SIBO after vaccine, according to my own experience and research data. In a recent study, a glucose hydrogen breath test was given to 450 consecutive patients. 200 patients with GERD who received PPI for a median period of 36 months at full dosage. 200 patients with IBS in absence of PPI treatment for at least 3 years. 50 healthy controls that had not received PPI for at least 10 years. So, these are the inclusion criteria. And main exclusion criteria I will show now. Okay. Main exclusion criteria were history of neoplasia, malabsorption, gastrointestinal surgery, metabolic diseases, use of antibiotics in the last 6 months, use of laxatives in the last month. Each subject was given a symptom questionnaire, and glucose breath test was performed with gastrolyzer instrument. SIBO positive patients were treated with rifaximin 1,200 mg a day for 2 weeks. Rifaximin alpha polymorph is a well-known non-absorbable intestinal antibiotic, and assessment of SIBO eradication was made by glucose hydrogen breath test 2 months after completion of treatment. Statistic evaluation were performed. And now the results. SIBO was detected in 50% of patients using PPI, 24.5% of patients with IBS, and 6% of healthy control, with a statistically significant difference between patients using PPI and those with IBS and healthy control. The prevalence of SIBO increased after 1 year of treatment with PPI according to the duration of treatment, over the value of 75% after 5 years of treatment, and so did the intensity of related symptoms. The eradication rate of SIBO was 87% in PPI group and 91% in IBS group. Statistically, it's more frequent in patients on long-term PPI treatment than in irritable bowel syndrome patients and in healthy control. The measured value of the study comes from the opportunity of having studied patients on PPI long-term therapy without influencing comorbidities, IBS patients and healthy control free from PPI use. The eradication rate was very satisfactory, and in the follow-up study we have assessed the outcome of 125 patients 1 year after the eradication of SIBO through the hydrogen breath test and symptom questionnaire. 87 from PPI cohort, 45 patients from IBS cohort. At the end of the study, 4 dropouts in PPI cohort and 3 in IBS cohort were registered. Among 83 patients from PPI group, 45 continued treatment with PPI for at least 9 months and 38 discontinued it. After 1 year, 10% of patients on PPI and 92% of patients who discontinued PPI were SIBO-free, asymptomatic, with a statistically significant difference. Among 42 patients from IBS group, 14 were subsequently treated with PPI for GERD symptoms for at least 9 months, and 28 did not take PPI. A control after 1 year, 36% of patients on PPI and 96% of patients not taking PPI were SIBO-free, asymptomatic. The resulting 52 patients affected by SIBO were re-treated with rifaximin 1,200 mg a day for 2 weeks. 90% of them resulted eradicated from SIBO. In a recent meta-analysis by Wei Kit Law and Walter W. Cheng from Boston, Massachusetts, 11 studies using duodenal aspirate culture and or hydrogen breath tests involving 3,134 patients were analyzed. To be included in this meta-analysis, studies were required to be randomized control trials or case control studies or cohort studies of PPI users versus non-PPI users, to include a non-PPI control group, and to diagnose SIBO by one of the current reliable clinical tests, namely aspirate culture or breath testing. The overall results of this meta-analysis showed a statistically significant increase in the risk of SIBO in PPI users versus non-users with an odd ratio of 2.282. But more important, subgroup analysis revealed an odds ratio of 1.93 in studies that use glucose hydrogen blend test and an odds ratio of 7.587 in studies that use duodenal jejunal aspirate culture to diagnose SIBO. Also, studies using a self-control or pre-test post-test design in which subjects were tested for SIBO before and after PPI exposure demonstrate a definite association between SIBO and PPI use with an odds ratio of 9.6. Although there is a significant heterogeneity in results among studies, so far 6 out of 11 studies report a statistically significant increase in SIBO risk with PPI use. This increase is definitely established in studies using aspirate culture, a method considered a gold standard for SIBO diagnosis, and in studies using pre-test post-test design. Conclusions resulted elusive in a retrospective studies where exact duration of treatment was not feasible or even not calculated. Taking into account that most bacteria are killed at pH 4 within 30 minutes, considering the physiopathological plausibility based on our own experience and research data, we think that a significant increase of SIBO risk after long-term treatment may be considered as an established fact. And differences in results derive mainly from study design characteristics that, in my opinion, are to be considered as critical biases: retrospective versus prospective design, types of tests used, and last but not least, the exact evaluation of duration of treatment with PPI. In fact, significant differences may arise between PPI users from Wuhan 6 months and PPI users for 12-24 months, often grossly reunited under the umbrella definition of long-term users, especially in a retrospective study. We think that PPI long-term treatment, at least 1 year, should be tailored according to 2 targets: tissue repair maintenance and physiological respect for gastric pH, in order to avoid bacterial transient contamination to shift toward permanent pathological colonization or over SIBO. In this setting, and under these modalities, treatment and retreatment of SIBO with rifaximin at high dosage have proven to be a clinically useful medication. Clearly, further studies are warranted to more precisely assess this complex problem from the etiologic, therapeutic, and possibly preventive point of view. Thank you for your attention.
Have you ever analyzed the microbiota shift after PPI treatment in patients?
No, but the microbiological spectrum is wide and approximately all the species can be represented, are present. There is no specific strain evolving from this population of microbes. They are aerobic and anaerobic as well.